Okay.
Okay, good morning, everyone. Welcome to our third day of the meeting. So I'm going to do a 2-minute recap of what we did yesterday and then hand over to our presenters. So we started off with the South African team presenting on their drug demand reduction programs, and we looked at the University of Cape Town, University of Western Cape, and Lenticare Psychiatric Hospital. And we looked at the different populations that they target, so from community engagement to a professional academic degree to psychiatrists and registrars that we train. And then thereafter, we had a group from Tanzania, Botswana, and Mozambique speaking about their drug demand reduction programs. We had Dr. Kieti Agnes from Uganda Hospital, who gave a very impressive presentation, and I think we were all impressed with the amount of work that one person does in Tanzania. I mean, it's so much, and it's really overwhelming. So congratulations, and we have a lot of respect for the work that you're doing. And then we had Pastor Christine Risho, also from Tanzania, and I think it's very refreshing to see the church playing such an active role, and often we look at the church and we think that they might take a moralistic view, and you gave us a whole different perspective, and that was very inspiring. Thank you. And then we had Dr. Claudio from Mozambique who spoke to us about their program in psychiatric clinic clearance, and I think what stood out for us was the limited number of psychiatrists in these countries. And if I recall, Dr. Claudio said there were about 17 psychiatrists in Mozambique, and how really the workload is on the psychiatrists. And what was interesting, the concept of psychiatric technicians, which was something new for most of us. And then we had someone from Ghana's Dr. Eugene speaking about their programs. He's a consultant psychiatrist and lecturer, and he spoke a lot around the myths about alcohol and drugs, which was very new to us. And then finally, we had Dr. Francisca speaking to us from Kenyatta University about the development of an integrated DDR program. She spoke a lot about how they've integrated HIV into the program, especially into them in the medical school, and how it would be to incorporate some drug demand reduction modules or programs into the medical school. And lastly, we had Dr. Mikhail Mayaski and his team talking to us about implementation of drug demand reduction programs, what's the steps one needs to take. The students spoke about an organization, what it to take to develop an organization. It's quite an active presentation, and we spoke about a collaborative approach, but also looking at sustainability. If we start something, how do we sustain that? So very shortly, that was a recap yesterday. Thank you.
Okay, today we have just a couple more countries who are going to talk about, well, the countries aren't actually going to speak. We're going to have presentations about a couple more countries, and I'm going to just have you all introduce yourselves. We're going to start with Rwanda.
Good morning. My name is Becky Wright. I am on faculty at the University of Illinois at Chicago, but I've never worked in Chicago. I've always worked in Rwanda. And I've been there 4 years, and I dearly love it. So, and I'm working on a doctorate, but at my age, I'm going slow. And I was lucky enough to have a colleague with me, Dr. Cindy Cassidy, so I'll let her tell you a little bit about her and then move on and talk about Rwanda. You have to get in the spotlight.
Good morning. I'm Dr. Cindy Cassidy. I'm a clinical psychologist. I'm with the University of Kibungo, which is a private small university in the eastern province of Rwanda. And I've been in Rwanda almost 5 years now. Thank you.
Great, thanks, Cindy. So we're the land of 1,000 hills. And for me, I'm a nurse practitioner. So I worked like an emergency room physician for over probably 25 years. And they would always say, Becky, go take care of the psych patient, the person with mental health, the addiction. So I went back and got a second master's in psychiatry and then a master's in nursing education. So I think that's really important. So Rwanda, we're small. And so this is for you that I didn't know, but we're big in heart. And I'll talk a little bit about our population. So I work at the University of Rwanda. It is the only private, public university in the country. And it was developed in 2013, so it's really, really new. It was a vision of President Kagame. They brought together 14 universities and came to one. So you can imagine what that was for Reconstruction. We now have 30,000 students. We graduate over 8,000. We now have, and I was looking last night, I think we have 14 PhD programs and about 36 master's programs. And I can tell you, I helped develop 8 masters in nursing, and my next is a master's in nursing mental health, and also with a twist on, and it's really highly in addiction, of course. And then I'm working collaboratively with Cindy to develop a master's in addiction. So I think it's important that we know that the University of Rwanda is shining, okay? We are now tied with Johns Hopkins University in citation. And believe you me, their budget is much bigger than ours. So our research is really taking off. Yeah, we really like equality. We think that our people in Rwanda should be cared for just the same as any person in any country, low and middle income country. What brought me there was a $152 million project with President Kagame and President Clinton called the Human Resources for Health. So we built infrastructure in health in all forms of medicine, but also in hospital management. And we're at the end of that cycle, and it's been incredible. We also like tolerance and mutual respect. And that's super important in our university. Our Vice Chancellor, Professor Phil Cotton, who used to run the Glasgow Medical School, he's got an OB from the Queen, and he's the most humble man you would meet. And literally, he goes to his office at 5:30 in the morning, and he tells anyone, come in, any faculty or student does not need an appointment to meet the Vice Chancellor. So it is truly amazing. He is a president appointee. He also runs the Rwandan Biomedical Center, which is all the medical supplies and the medicine for the country. So we really do have some good things going. Scholarship, of course, research is big for us. I'm doing research now, match sample, HIV, non-HIV, cardiovascular risk factors with a mental health twist. We just finished a focus group on, and that is with University of Illinois Chicago. We just finished with Duke University, a stigma forum, and now we're piloting a stigma reduction tool, getting ready for an R1. And this stigma reduction tool is for HIV, for women suffering with HIV, but it's something that I think I'll pilot in mental health. We have a couple more things on the board. With Columbia University and University of Chicago, myself and a male researcher did the first study of lesbian and gay women in Rwanda, and bisexual, looking at substance abuse and access to care, which was pretty amazing. And accountability, we encourage everybody to be together. I think our vision, we want to be internationally known, professional teaching, scholars, and a lifelong learning and creation and reflection to the community, but also to global. And President Kagame is quite the leader, and I think this is the time for substance abuse and addiction. In his 5th National Dialogue, which just happened, he pretty much said, the war on drugs has begun. And Rwandans owe it to themselves, to the future generations, and to collectively tackle this vice of addiction. And my partner at the University of Rwanda is now the national representative for the youth and addiction in youth. So it's Dr. Darius Gashoma. So our population, as of last Sunday, we were 12.6 million. That's scary. By the year 2020, we're going to be 16 million. The age structure, we're super young. Okay? And it's really, really tough. And so there's just some statistics, and for time, I won't run through it. And this is also Rwanda population in terms of male and female. So if you look at this, we are quite a young society. And you see it when you go around. But of course, we have the genocide. In 1994, 1.9 million perpetrators killed 1 million people within 3 months. Genocide continued for quite a long time. But it's important. So we had the first official commemoration in 2004. mental health was included then. So the commemorations of 1994 did not always have mental health services, and they were overwhelmed. We go to the Amarillo Stadium, the president speaks, we have dances and things come. So this was centralized, it was reactive, and they got totally overwhelmed. And when my colleagues tell me about that time, I'm like, oh, ho, ho. So, and then statistics show that 99% of these people witnessed violence and 31% were raped or sexually abused. And rape was used as a weapon. Over 250,000 women were affected. And interesting, research is going on now to look at the children born of the rape of genocide. And we are finding that there is a propensity for PTSD and anxiety in those children. And they think it's could be genetic, nature versus nurture. So we have some interesting things going on. But think about it, next year, it's our 25th anniversary. We start on April 7th and we go 100 days. And it is very solemn, but it also is very respectful. And so in 2013, and I arrived in 2014, so I was in the very beginning of this planning for this, is that we created a decentralized network. We trained over 15,000 community health workers how to deal with issues around genocide, PTSD, substance abuse is rampant during this time. So they put on, especially on the radio, things to help. You know, don't drink, be careful. And so we have well-trained mental health responders throughout Rwanda, and I go to quite a few of the university sites, that's where I go. So it's been very interesting to encourage people to be safe. So getting away from genocide, we need to talk about what do we have in Rwanda now. So remember, everything was wiped out. We had one psychiatrist, Professor Nasson. His wife was the second PhD nurse, mental health nurse in the country, Dean Dr. Talamukimana. She's our Dean of the School of Nursing. So we really have grassroots going on. We have 12.6 million people. We have 8 psychiatrists. 3 more graduated from Belgium, thanks to Dr. Nasson. Mental health nurses, we have around 500. Their level of education is what we call an A1, or diploma. Some have gone back and got bachelors. And then we have 8 masters. They mainly work with me in the School of Nursing. And we have 3 PhD. One is at the Ministry of Health, and the 2 are at the University of Rwanda, and those are in mental health. But we are working now on how nurses are able to prescribe. Nurses prescribe at the A1 level, but they're not like I am as a nurse practitioner, recognized in the US to work just like a psychiatrist. Because I can do everything in the US except for I don't do electroshock therapy. And but it works. So I do, and I've done a lot of community and critically ill mental health patients. I do detox, I can do naloxone for narcotics as an advanced practice nurse in the US. This is where I think Africa can really benefit from taking their nurses, educating them alongside the physicians and the psychiatrists, and building that workforce at the core of the community. And that's what we're going to do in Rwanda. We have no choice. So we have, down in Butare in the south, we have mental health services and we have psychiatrists there. We have Shiashika or CHUB. We have psychiatrists and outpatient there. Then we have Indira, and that's our neuropsychiatric hospital. And it is very busy. And then we have a small outpatient called ICUDDR. So if you are sick mentally, you're going to get transported back to Indira or back to ICUDDR. Okay? Partners in Health has implemented a program where they train mental health community nurses in a pretty extensive way in mental health, and that will be published very, very soon. So the University of Rwanda wants to collaborate with them because we think it's important. Our other issue is access to medications. So I'm going to talk to you about the mental health survey that Johnson & Johnson is helping us. So current mental health, I kind of went over it, is that ICUDDR provides the only specialized treatment for PTSD. And I have some studies around PTSD and substance abuse. So this was a current study, and what we found, they did a chart review of the patients that were in the outpatient. There were 719 patients. They just selected almost a 1 year period, and they had a large amount of males. They had profiles, they were more educated, and they were likely to live in the capital. So that's important because socioeconomic access to mental health care is the issue. We had AA there, and when we bought juice and we trade for transport, people came. Now they do not come because they cannot afford it. Our average income in Rwanda right now is $574 per year. So it's low. And most patients didn't have issues, but only patients diagnosed with PTSD seem to improve. But the most common diagnosis were psychotic disorders. And that's a concern for me. I want to make sure we really do diagnose psychotic disorders well. And then substance abuse is right next to it. So we have a PhD nurse that is going to be finishing PhD in addiction. I'm very excited. Bonifest, this is his thesis. He's developing an addiction care model of patients, looking at engagement, finding out what they need, and retention. So what he's found so far is that a lack of a therapeutic relationship with the nurse, with the care provider is one of the biggest barriers. And also lack of medications and access to social support. So many of us are in psychiatry, and we know that social support at the family level, at the community level is so important. And of course, cultural stigma. We also have one more drug treatment place which is kind of different. It's called IWAWA, and it's to re-educate and rehabilitate. There's 2,000, they're males only. They're ages 18 to 35, and they're placed on an island in Lake Kivu. And it's 17 miles from the mainland. The issue is they don't have a lot of aftercare, so we get a lot of repeats. But it's an interesting concept. So let's talk about Rwanda as a culture. In the history, we're really harsh on deviant behavior. And this is a quote from the addiction PhD nurse. And so when we look at issues of like suicide, these are the quotes that I found as I went through the New Times TV or New Times newspaper. Suicide is murder. Suicide is totally immoral and ignores the sanctity nature of humans. Suicide is an act of cowardice, a trait of our ancestors and families should never be tolerated of any kind, and hence making it illegal. So when I talked to therapists, he said, females with substance abuse and major depressive disorder are 3 times at more risk for suicide. And within the last month, we've had 3 suicides within the big city of Kigali. So it's a concern how suicide, how major depression all comes together. So prevalence of substance abuse in youth in Rwanda, this is a 2015 study, and it shows, it was a cross-sectional home study. So they did 2,479 youth, 56% were male, 44% were female, and their ages were 14 to 35. And they randomized this, 20 out of the 30 districts, and they did a questionnaire and self-reported drug use. My only concern is substance abuse and drug use is illegal. So that we want to make sure, and this does have pretty good confidentiality, but I do think numbers get skewed in research. So alcohol disorders, they use the ADDIT. For cannabis, they use the CAS, and they use the hooked on nicotine checklist. These were all validated in Kenya and pilot tested. So 34% had used alcohol, 8.5 tobacco, 2.7 cannabis, and 0.2% glue, and 1% benzodiazepines. And you can buy them right over the counter. And they're cheap. 7.46 or 1 in 13 are alcohol dependent. 1 in 20 are nicotine dependent, and 1 in 40 are cannabis dependent. This is 2015. Numbers are rising. So there was also a prospective study that's ongoing, and this was this was also benefits, I'm sorry, I got it kind of backwards, but we're going to skip that because it just talks about his study again. So this is another study that was done in 2015, looking at health, both mental and physical, 14 years after the genocide. And they used the mini international neuropsychiatric and mental outcome study. And the participants were PTSD were significantly more affected, as you can imagine. So we have things to help our people. We have Umaganda. Umaganda is the last Saturday of every month. And it's a place where we get together and we clean our country and we dig and we go together. And I tell you, when you come to Rwanda, you'll be amazed. There's no lid in it anyway. It is picked up. And I've been told that if President Kagame drives by and there's litter, he calls and the president out of Uganda doesn't take care of it. So anyway, and sometimes when you go to Uganda, there'll be 300 people. We work for 3 hours together, and then at 11 o'clock to 12, there's a meeting. And it's illegal to be driving or not be part of Uganda. So wouldn't it be incredible if we could start education on substance abuse? It would be very open from that 11 to 12. And that's maybe where we could find our leaders that then could go out in the community more. We also have a thing called Umadugudu. So that's smaller. So that's where the local cells, 4, 5, 6 areas get together. And if I'm having a problem with my husband, I would go to you as the Umadugudu leader and say, I'm having a problem with my husband, he's drinking. Can you help me? And so I think that would also be people that we could use and train to be the people that would be leaders against substance abuse, gender-based violence, those kind of things. So there's also the Interministerial Committee on Drug Control. So those are all the religious organizations and NGOs that are faith-based. And they report to the Prime Minister on a timely basis. This is chaired by the head of the mental health, Dr. Ivan. And they have sensitization activities, and this is mandated by law. So this is another place that we can bring in what we're doing. They even do outreaches in the schools, but they also do outreaches in the market. They'll put up a tent, they'll get on the megaphone, they'll maybe serve some drinks because people come for that. And I think that's something we could do. And they visit inpatient facilities in Rwanda. So just last week, the Mental Health Survey 2018 came out. So we're really happy about that. It was a wide cross-sectional study that combined 2 samples. They looked at population between the ages of 14 and 54, and they documented the prevalence of PTSD. The general population, they randomized that to 240 clusters, and they did systematic mapping of 30 households, so the sample was big. And then they did purposive sampling for the genocide victims, so they separated them out. And they used the mini International Neuropsychiatric Review. So here's our results. Prevalence of mental health disorders, 14 to 65. So substance use disorder is low, but I find it interesting that alcohol use is here, but major depressive is way up there. I think major depressive has hidden alcohol usage. So I think it's concerning because if we don't treat that major depressive disorder, it's a problem. And this was a sample of about like 9,000 people. So this showed the prevalence by district. So outside of Rwanda, outside of the big city in Huye and Gasabo, very, very high. So it's interesting. So we know that the areas of the Northwest had lower incidence and the East, but areas of the way north and the south are very, very high. And you can see it when you travel. So, reported utilization of mental health support. Oh, this is bad. Only 5.3% use mental health services. Stigmatization. Okay? I can tell you that's the main thing. So percentage of prevalence of disorders, and this is from the 24 to 65 range. Bipolar, but look at major depressive again, PTSD, alcohol use disorder at 4%. Suicide disorder, remember that is illegal, so who knows? So we don't know. So these are pretty significant. PTSD and panic What do people use for panic? So I think we've got some real statistics that have some underlying issues. So, and these are the comorbid with PTSD. So PTSD even has higher levels. Alcohol use disorder at 6.8. But look at that major depressive disorder. 68. It's high. Oh, really high. Panic is very, very high. Yeah, 68.4% of major depressive disorder in the people that suffered during genocide. And it's not the people that were attacked, it's whether you witnessed, whether you were there, okay? So that's important. So, levels of mental health services known to the genocide survivors. Oh, they know about it, okay? Many people will use traditional healers, the community health workers, and our community health workers are trained by the Ministry of Health, RBC, but they're lay people, okay? And they do the best job they can, but that's where I think our community support can go on. So, and religious leaders too are very, very important. So, reported utilization of mental health support. So, still small in this group. Okay. So, conclusions. Rwanda needs to make a comprehensive promotional approach to mental health disorder and co-occurring. We need to create programs and packages to strengthen mental health. We need to reinforce capacity of all health professionals at the community level to access and treat early. Fight stigma. That is the one reason I did this lesbian study. Now I want to do a study on people with disability, and now mental health, because stigma is big. And if anybody's interested in this program we're using, it's pretty innovative. I can talk to you about it later. But we need to increase the focus on improving mental health and well-being with all genocide survivors. We have to move forward. And I know I've talked a lot, and I think you would. So here's just my references. And I'm sure you would like to hear maybe from Dr. Cindy if you have something to add. Thank you.
Thank you.
Mm-hmm. What number is it? One? Yeah. Slide one. There it is.
Okay, thank you.
There are 2 points that I want to add. The first is that we have more than 1,000 clinical psychologists in the country. Clinical with a bachelor's degree. Few have master's degrees. They're not being utilized. Probably 80% of them are unemployed. Part of the problem is the concept of how to utilize clinical psychologists. The belief traditionally has been that there are places in the hospital and clinical or medical settings. And I think we need to expand and broaden how we utilize that group of individuals. Recently, I've been placing interns into secondary and primary school settings to serve as psychologists within the school settings. I believe we have to begin with our youth. And the younger they are, the more hope we have for decreasing depression, PTSD, and anxiety, and substance use disorders. The other issue that I wanted to talk about is for me it's interesting how alcohol use disorder is separated from substance use disorder. And this, I think, is a cultural issue. Alcohol has a rather, I don't know if I can say this, but sacred place in Rwandan culture. Alcohol is prevalent. It's used at weddings. It's even used at funerals. It's used at baptisms. It is the go-to after work for men. And it has a very traditional and almost revered place in Rwandan culture. So trying to get rid of alcohol is going to be a challenge. Our bars are open until 4 a.m. And so this is a difficulty. But it's interesting how substance use is separated from alcohol. It's as if alcohol is not considered a substance.
Mhm.
So those were the two key points that I wanted to add. Thank you.
Questions? Okay.
It's over to you. Very much. You.
Thanks so much. Perfect presentation. I can assure that it is not culture issue because many people in Europe think that alcohol, beer and wine is not alcohol. In Europe, but not only. My question is, I'm really astonished when it's still mentioned, emphasizing the nurses' role and the potential in drug dealing. I have a continued program with my own nurses from my department in healthcare in Czech Republic. I think that the situation in other European countries are quite similar. They have a so politically correct. They have no enough self-awareness to self-support. And when I speak with them, there is going to develop something like specialization addiction, create specialization addiction nursing, and develop some specific self-supporting training activities specifically dedicated to nurses. How we can I don't know how to support this activity because when I see the situation, especially in the US, you have a addiction nurse, you have a top journal, addiction nurse, is in journal, prestige journal, and many active people around the United States. And now I can see that it has an impact in different continents, different countries. How do you support them, engage them? I don't know, practically.
Thank you. I can give it one word, money. Okay, as a nurse, as a bachelor's nurse, I made 60% more as an advanced practice nurse. And I think we have to put our money where our mouth is, you know? And so we have to go to the boards of nursing of these countries and say, I need these people to be on leave. I also was trained by psychiatrists. I picked who I trained with. So it is the nursing, the core. They're the licensure. You have to have your licensure first to be able to work like you do. And also you have to set high standards. If you don't not set high standards and raise the bars for nursing, you will not be successful. Okay? That answer your question? Okay.
Thank you very much. Please, is it possible to go back to the slides on the mood disorder, particularly in the question? So can we go back to that slide?
Oh, yeah, no, I just opened up the next presentation.
Yeah, something 68% or so. Or something 68%. Yeah, I want to ask whether, now dealing with this, very interesting what you said about getting psychologists in the school system, very interesting. But I also want to ask whether there are cultural approaches you may wish to explore in dealing with this level of mood disorder. Because I was surprised to see alcohol abuse or alcohol use disorder quite low. In many societies that you experience high level of mood disorder, whether depression, whatever, many times find alcohol issues very high. So first I couldn't reconcile the relationship. It's possible in terms of definition, okay? Given the background that alcohol use may not be considered alcohol misuse may not be considered a mental health issue, where it's seen as a social relaxing, you know. Yeah, but so first, not able to reconcile the relationship between this low level of substance use disorder and high level of major depressive disorder. And the second question, whether there are attempts to explore cultural means like dance and so on, art therapies and so on, in managing this high level of mobility. Thank you.
Can I address that question so I don't forget it? So I think your first question was why the discrepancy between the high rate of depression and the lower rate of alcohol use disorder and substance use disorders. First of all, I think that many people with an alcohol substance use disorder would not self-diagnose themselves. They would not think they have a problem. So you would not tick that box. The second is you have to remember that substance use disorders are illegal. So you don't want to out yourself, right? And this is another, if you notice the, what's not on this slide, but if you notice the suicide rate, extremely low. It's illegal. Suicidal attempts are illegal. So you're not going to admit that problem. So I think that's what skews the statistics.
And we do use dance. We have quite a bit of dance and that kind of thing for reconciliation. They talk about mental another. So yeah, we do quite a bit to support. But I think she's totally right. Many hidden things.
Okay, I just want to talk about the issue of clinical psychologists. I spent something in my own country, one of the departments of psychiatry in my university. I had only one clinical psychologist. One of them was a research fellow in the department, but one was actively working. So I now made a proposal that I needed more clinical psychologists. That I made a position for me and our colleagues and the management. What are you going to do? What is the role in the So we had to have a workshop on how to develop the hospital. So I made my 5-year and 10-year development plan, and I told them that I needed a minimum of 12 clinical psychologists, and I wanted each team, psychiatric team, to have clinical psychologists. They said, "Why you are crazy? Why need this?" So I now have to find out what happens in other parts of the world, and then I had the opportunity to do some small work in the UK, and I told them that this is how it's done, and if you want to be really effective, pharmacotherapy is just one aspect, but you have to do psychological therapy, social work to continue to maintain the recovery. So I now argued and I said within the next 10 years, I should have at least 12 clinical psychologists for all the specialties that we're developing. But after 10 years, I have only 4. And so I had to go to the psychologists in my department, some of them in the university, and I said, you are not marketing yourself. You have a professional association. What are you doing? I'm a psychiatrist fighting for you, but what are you have to make a strong case for yourself so that the government will know that we are needed. And even before I have my government, I was saying because they work in other aspects for the whole teaching hospital, only 4 clinical psychologists. But my NGO has 4, and I even have 4 clinical psychologists, and then I have even 1 volunteer. So I have more clinical psychologists in my NGO. Local small into that, even the university department. So I think it's maybe a problem in this part of the world, and we really need to work and we get them involved in all the treatment. And I say, psychiatry is a teamwork. I cannot do it alone. Psychiatry is a teamwork. And if you don't do it, then you're wasting resources on me because I will be very effective. If you want a result, I need a team, and I need the nurses, I need the medical psychologists, the social work, everybody, so that we'll be able to deliver. But I think we need to make progress. Thank you.
Thank you. I'd like to add to that. That was brilliant. Thank you. I think we're dealing with the same issue in Rwanda. Coming from the US, the role of a clinical psychologist is you diagnose, you treat, and you collaborate. And you are in many, many different settings, forensic settings, school settings, hospitals. You work with a parish. You set up private cabinets. That's something that has not been, I've not seen it here. So I think we, as educators, we need to start with our curriculum. I think we're putting clinical psychologists in a box, and we need to really start thinking outside of that box, and perhaps not even calling it a clinical psychology program, call it psychology. And yes, and then you have a general background in psychology. I mean, we have sports psychology, we have medical psychology, we have forensic. And one of the programs that I want to bring to the University of Rwanda is a master's degree in neuropsychology. We have a high rate of epilepsy. We have TBI. We have disease, and we have addiction, and we need to rehabilitate people so that they become part of the workforce rather than a financial drain on government resources. This is psychology, and so I think once we as psychologists begin thinking about our contribution, the sky's the limit.
I'm so sorry to interrupt, but I do want to let Botswana have their presentation. They're the last country to do so, and hopefully we'll get a break, and so you can have the conversation. Okay, thanks. Stand so we can see you in the camera. Yeah.
Good morning, everybody. Thank you for your time. My name is Lynn Mosomani. We are coming from Botswana, Gaborone. I'll give you a little bit background of Botswana. Botswana is a very small country. We are a very landlocked country. We're about 2 million. So you can imagine our brothers over there. And when I come from Lagos and go to Botswana, I will be looking for people, I'll be missing people. Thank you. Yes, we are located in Southern Africa. A lot of people, when you say Botswana, they think of South Africa. We border South Africa, we are from South African country. We were lucky to have privilege to be introduced to UTC training program, which was sponsored by the Minister of Health. And during that time, a lot of teachers, psychiatric nurses, police forces, and doctors were the very first people to be trained. But some of these people are not really on the ground. Hence, there's no taking all the services to the people who are in great need. So we are representing the Lekanalo College. We are coming from the Department of Counseling. I've got a background history in psychology, clinical and counseling psychology. So our main interest here is to develop a postgrad diploma in addiction counseling, of which we have already started by identifying the need assessment. So my colleague here will introduce herself and then take you through the process of how to develop the program. Thank you.
Good morning, colleagues. I am unfortunate that I was not able to be here yesterday. Mama Sumani told me about the presentation and how it was very interesting. For those that I had not met on Monday, I was here on Monday though. My name is Dr. Moreko, as was on the slide. My background is actually forensic psychology and clinical psychology. I also did recent training in addiction. So it's interesting to hear people talk about our profession. So I think for us clinical psychologists, we also have to have a voice in making sure that people understand where we fit in terms of addiction field and more especially in terms of mental health. But this is not the topic. Our topic today is focusing on how as an institution we develop a program. Next slide. But before I go into that, I will just want to share with you about our college and the vision. On Monday, Dr. Beatrice actually talked about the importance of having an institutional vision that actually supports why you have to develop or why the need to develop a postgraduate diploma in addiction or whatever it is or the program that you intend to develop. Our mission at ICUDDR College is that we change lives through healthcare, education, and training. And therefore, it is very befitting as to why we are in this process of actually developing such a program, because we want to change lives through our training, and hopefully it transcends into service provision by our graduates. And our mission, I don't know why it's not showing.
No, it's doing this. It's coming.
We take pride in sharing that we exist to produce competitive healthcare professionals through industry-driven programs. This is very important to us because the programs that we offer at ICUDDR are industry-driven, so that we meet economic needs for the country, the region, and globally. Now, just diving into the main focus of our presentation is the process of how we develop programs. More specifically for our presentation is developing a postgraduate diploma in addiction counseling. You know, we've had a tussle and fight about why should it be a diploma, why should it not be a degree, why not a master's, and I will share with you shortly in terms of, in terms of why we chose to focus our program to be a postgraduate diploma. Now, in Botswana, when an institution decides or thinks about developing a program, there's where we start. At least we are fortunate to say that we have been given guidance by a regulatory body called Botswana Qualifications Authority. It's an autonomous body, which I want to believe in all countries you do have a regulatory body in terms of bodies, in terms of institutions developing programs. It's actually responsible for all qualifications from early childhood to tertiary level. So to ensure that all programs that are developed in the country, we do have BQA that actually looks at all qualifications. Now, this is very different because I'm talking about qualifications, not programs. So it's qualifications here, it's primary level, right? Primary education, tertiary education, and all that. So for tertiary education, we're more likely to be looking at certificate, diploma, and all that. They are not only responsible for looking at development of qualification, they're also responsible for looking at accreditation and development of curricula or learning programs. They also develop and implement and maintain an overarching credit and qualification framework. In the southern region of Africa, I know in South Africa, they also have a similar regulatory body. What is it called? ISSUP, yes. That actually oversees development of qualifications before people can develop programs. So that is really in a nutshell about National Credit Qualification Framework. They design and develop and implement a common quality assurance platform to regulate and regulate compliance thereof. They register and validate qualifications. I've already said that, to ensure their relevance to social and economic needs. I can go to the next slide. And they accredit learning programs. So in terms of program accreditation, here I've now moved to program accreditation. Obviously, it starts with a registration and accreditation of an institution to be an education provider, which is very important. I think this is very important when you think about actually joining ICUDDR, that you actually have to be registered to be an education provider in your country. So BQA ensures that for any program that wants to offer a program, they're registered and they're accredited. And now, just to go back, BQA, before then, we had a regulatory body that actually mainly focused on registering and accrediting learning programs. But since 2016, BQA came into place and it actually oversees the qualification as well as the learning programs. Now, it also oversees registration or an accreditation of other qualifications. So in Botswana, you cannot develop a program until you have a qualification that is already accredited. So you have to have, it's like a framework of all qualifications that are needed in the country. And when you have such, then you can come and say, I want to develop a postgraduate diploma in addiction, because you already have an outline or a framework that actually indicates the qualifications that the country actually needs. And then, of course, then after that, there's registration and accreditation of a learning program. Just to give a bit of a summary in terms of the National Credit Qualification Framework, I'm not quite sure whether other people have the same, okay. It's an instrument developed for classification of qualification according to a set criteria for specified levels of learning achieved. It outlines the bare minimum standards of a program at any given level. The set criteria outlines the number of credits, or maybe let me take that back. It outlines the minimum number of credits that are required for a particular qualification. For in our instance, we know that BQA has a bare minimum of number of credits that are required for the postgraduate diploma that we intend to offer. With regards to tertiary education, there are about 5 levels outlined. At level 5, they do have certificate. Level 5 is certificate. It also outlines the number of credits that that qualification has to have. And then level 6 is diploma. Level 7 is degree. Level 8 is bachelor's degree and honors, postgraduate certificate, postgraduate diploma. And you know, this made me think about what is the difference between a postgraduate certificate and a postgraduate diploma. This is for us to think. Because it seems as if according to BQA there's a difference. And I was asking her whether anybody offers a postgraduate certificate, because we are trying to fiddle and understand what is the difference between the two, because clearly here they're put in the same level. So it means the bare minimum credits obviously are the same, but obviously the content and all that is going to differ. And then level 9, it's master's, and level 10, it's doctoral degree. Just to share with you, I know I've not put a lot of the information in terms of the credits here on the slides, but for postgraduate diploma, they calculate the number of credits that we usually know. We know a course sometimes is 3 units, or 3 credits, or 2 units. They've got a step ahead in terms of calculating what is called the notional hours. So notional hours actually is very inclusive. It includes the number of hours in terms of preparation, in terms of tests, all that. And that is what BQA uses as the bare minimum number of credits for a particular qualification. So now we are aware of where we need to start. We are aware that, okay, fine, the qualification, this is the bare minimum of what is required in terms of credits. Now, the requirement there then is to actually develop the qualification or the qualification process. The first thing you need to do is to establish the need for that qualification. As I said earlier on, the question is, why should we start at certificate or degree or postgraduate? So we need to establish the need for that particular qualification. You need to do a stakeholder engagement and outline the qualification profile. So just to unpack establishing the need for the qualification, go to the next slide. At ICUDDR, we actually did a desk reviews in terms of looking at what qualification are we going to be focusing on. And this was mainly driven by the fact that most of, like some of us have done UTC, we are trainers of UTC. And the issue has remained that we are not able to translate for now UTC into credits that fall under these levels, because it's not quite clear for BQA if a master's person can take it, PhD can take it, undergrad can take it and they have the same certificate. So I think that is one thing that actually propelled us to be thinking about how can we take some of the contents from UTC and try to make it more palatable maybe to our people so that they can actually have something that is equivalent to a tertiary education certificate. When I talk about certificate, it's just a paper for me. So we did a desk review. And from the desk review, these are just examples. Obviously, it's not comprehensive because we didn't want to focus on identifying the need. The Human Resource Development Council report has outlined the priority skillful workforce in Botswana. So it made it easier for us to look at what the country actually sees as things that are needed or qualifications that are needed in our country. And counseling and psychology is actually some of the skills that are needed in our country. Obviously, they did a lot of research to come up with such a report. So from the desk review, we know that actually there's a need. Besides the desk review, we did a lot of literature review. There's a lot of publication that actually indicates that there's a growing problem of substance abuse, more particularly amongst the youth. And most of the research findings actually comes from research that has been conducted in university settings, and just a few from NGOs or substance abuse rehabilitation center, which is the only one in Botswana. So we know that there's clearly a need because of empirical data that is indicated from the literature review, that there's a need for us to address this problem by offering how do we help, and we do that by offering a course so that people get skilled to address the problem. We are also conducting research to actually identify the target audience for the qualification. This is something that is very important to us because we've seen that addiction is a multidisciplinary profession, but we were trying to figure out who our target audience is, given that we are going to be offering it at a postgraduate diploma. And if this is the case, then we need to have people that have basic counseling skills. I know that we have nurses, we have people from public health and all that. So we are trying to figure out our target audience by actually conducting this research so that when we offer or when we admit the students, actually they have the basic requirements so that we don't find us having students struggling because we assume that they should be grounded at least, or have the bare minimum that is required for one to do counseling at least. One thing that comes to mind, because I know that we also have pharmacists in the field, I don't know whether they will be doing counseling. It's just a thought, like in terms of who the target audience is when thinking about postgraduate diploma in addiction counseling, because the counseling part is very important. And then also the research focuses on the type of courses that we will be offering, looking at the UTC, like the basic ones. The other stakeholder engagement that we had, I know some of the participants asked us about, what about courses that deal with addiction and the legal aspect? Because I know in UTC we don't cover that. So at least stakeholder engagement in some of these ongoing research would actually help us to really identify the need and actually come up with maybe solutions or ideas in terms of what it is that should be entailed in the program or the qualification. And then we'll also do expert interviews and do job profile reviews. The reason why we thought job profile reviews are important is because we know that everybody claims that this is their field. But when you look at the job profiles of clinical psychologists, their focus is not only on addiction, right? Even psychiatrists, pharmacists, and all that. So it will give us an idea in terms of what to include in the program. Now, the rationale of having a training needs assessment, I know that I'm talking to experts here, obviously is to provide a market relevant qualification, right? It is Also to outline exit learning outcomes. That is maybe what other people would call a graduate profile. So that we know that what is this person going to be doing? How are they going to be filling in the gap that we currently have in Botswana? So that we distinguish them from a social worker, from a clinical psychologist, from a psychiatrist, from an addiction nurse. It also informs curricular design. Important, it's also for comparability and articulation of qualification. We are required, as we develop qualification, to look at what other countries actually offer and to compare with what we are trying to actually come up with. So our needs assessment actually would help us in that, so that we can compare that in Australia, this is what they offer. In Czech, this is what they offer. In Prague, in South Africa, this is what they offer. So comparability and articulation, and most importantly, because remember I said that at our institution also, we exist actually to produce globally competitive healthcare workers. So our programs also have to allow students to articulate into other programs if they want to, or go into other programs in a more smooth fashion. So in terms of developing this qualification, that has to be taken into consideration in case somebody wants to transfer from one institution, from the region to another region. The second process is actually doing stakeholder engagement, which I want to believe all of us understand. For this slide, we just outlined who our main stakeholders are in Botswana, in our institution. The Ministry of Health, very important to us. So, because our counselors, when they graduate, we are hoping that they get employment from the Ministry of Health, and obviously because this is a healthcare field, clearly, the Ministry of Health has to be part of our stakeholder. And then the other stakeholder, very important, is the Ministry of Tertiary Education. Tertiary education, obviously, in terms of regulatory, but in Botswana, this is our butter and bread. So it is, the ministry actually is the one that offers scholarship to most of Botswana. So we can develop a program, but we need to know whether we have students, who will be sponsoring students. The Botswana Health Profession Council, very important because this is our regulatory body. Right now, I was actually talking to my colleague at the other meeting where I was yesterday about where we are going to be placing these graduates. Because right now, because I sit on the board for BHPC, for psychology, right now, we don't know if we're to come with a pharmacist who's an addiction profession, which board is going to regulate that person? So we need BHPC to be on board when we start, so that somewhere we will know that when they graduate, there's where they are going to be registered for them to actually practice. And then obviously DQA is the most important in terms of quality, in terms of adherence to standards. NGOs, and more especially those that actually provide service currently, whether it's empirical evidence or not. Right now, our issue is not whether they are doing empirical-based evidence. It is to get all civil societies to understand what we are trying to do. And hopefully, if they are not providing empirical evidence treatment, they would come on board actually to come and learn how to maybe actually do it more effectively. Or we can also learn from them how that things actually work. The other stakeholders is our students, our current students, our former students. Because they are the ones who are more likely to inform us where the gaps are in terms of what they got from us in terms of the basic counseling degree that we currently offer. And then Business Botswana. Business Botswana is very important because this is the market, like where the business people are in terms of what is relevant in the market. And then parents, sometimes we minimize the role of parents. These are very important to us as stakeholders. They pay tuition. They also actually are experiencing their children using drugs. They are affected. So these are just the few of, like if you were to do a stakeholder matrix and come up with the hierarchy, I'm not going to go that, but this is ours, but these are not all of them. Now, the next one, so we've identified the need, we've done our stakeholder engagement, but before I go into the qualification profile, let's just talk about the importance of stakeholder engagement. Obviously, as Beatrice said on Monday, it is to get the buy-in.
Yeah.
You know, you don't want to develop a program and then after that you develop a program, people ask you, but you were never involved. Right? So we want the endorsement before we can actually start offering the program so that we don't get stuck with a product and lose a lot of money. Remember, we are a private institution, so we cannot afford that. And obviously their contribution is not only about money, they bring about expertise in whatever field in terms of marketing and all that. So stakeholder engagement actually, it's important in terms of developing a program. Now coming to the requirement of BQA, we are now required to actually come out with a qualification profile. So what is the qualification profile of this postgraduate diploma in counseling? So you are required to actually outline the exit outcomes. What is this product that you are trying to bring? What is this graduate going to be able to do when they leave? Right? And that the exit outcomes actually set a platform in terms of your learning outcomes for the courses that you're going to develop, right? Because if they're going to do assessment, if they're going to do screening, if they're going to do psychoeducation, so you have an idea about if these are the things that this graduate is going to be doing, what are the courses that I need to develop so that they're able to actually do those things. And we are also required to actually outline specifically in terms of how we are going to assess the attainment of these learning outcomes. So you can go to the next slide. And I can talk, so I just have to make sure that I don't go on and on and on. We all know what learning outcomes are. These are statements that indicate what a learner should know, right? What they are able to understand and what they are expected to demonstrate. So like things about practicum. So already you know, if you're talking about demonstration, it's more behavioral components. If you're talking about should know, it's more about cognitive processes and all that, and understanding is also a cognitive process. So in terms of coming up with learning outcomes, these three things actually guide the formulation and development of learning outcomes. The qualification learning outcomes show what a learner is expected to achieve in terms of knowledge, right? To show what they know. In terms of competence, skills, people say skills. So we're looking at task skills, right? Task management skills, like are they able to manage the tasks, right? Are they able to have contingency management skills? If things don't go the way that they were planned, are they able to actually work within that environment? The skills that we also would be looking at is environment skills. Are they able to work within different diverse environments as an addiction counselor? And social skills, very important because we work in a multidisciplinary skills. This is just to give an example in terms of thinking about learning outcomes for your process. So when you do have exit learning outcomes, obviously the more global learning than course learning outcomes, it actually gives you an idea about like how many courses are you going to have. And bear in mind, we also have to bear in mind that we have the bare minimum by BQA. And then importantly, which most of us do not actually assess, is attitude in terms of learning outcomes. Important is that they should be measurable. Sometimes people come up with learning outcomes that we're not able to measure through an assessment. Be kind, like how are we going to do that? So they need to be measurable and achievable. I've already said this, qualification learning outcome are a platform to develop courses for the qualification. Just a brief in terms of assessments for the program. the assessment mode should definitely be aligned with the qualification level. So remember we said level 1 is certificate, not level 1, level 5, level 6, you go up. So our assessments actually have to show that they are aligned to the qualification that you're actually developing. So if you are going to ask a lot of recall, obviously it's not at the level of postgraduate diploma, right? They should also be linked to the learning outcomes. They should be formative and summative. We should have a mixture of them. And the modes of assessment should vary, should have test, examination, role plays, group activity projects, and observe practical work. And actually, this depends on the type of the course that you are offering. Obviously, some courses you will not have examinations, and then in some courses you will not have practical behavioral observations. But when developing this qualification, you have to articulate for every course how you are going to assess it. And for us, the assessments actually are only done by people that are registered and accredited by BQA to be an assessor. Because before BQA, we used to be required to have to be registered and accredited to be a trainer of trainer, TOT. Now you are required as a professor, as a lecturer, as a senior lecturer to not only have that, but to be accredited to be an assessor and a moderator. Because that takes a different skill. So all the assessments for you to be hired now in the institution, you have to have TOT, you have to be an assessor, accredited and registered, and you have to, the other one that they do not emphasize is for you to be a moderator. Other NCQF requirements, obviously you are required to outline your teaching methodology for all the courses. I'll rush it.
We're finishing.
Other requirements to outline your teaching methodology. For this course, how are you going to teach it? Is it online? Is it didactic? So for every course, you are required to actually outline your teaching methodology, whether it's blended teaching methodology. You also are required, the reason I knew that my time would be limited, so that's why I just put those. You also have to outline the order of your course offerings. First semester, these are the courses, and obviously they have to be in a systematic order so that you have like lay the foundation, go to the next level, you go to the next, and then they exit. So in terms of developing a qualification, these are some of the requirements that we are required in an institution by BQA. So it makes it a little bit easier for us when we think about a qualification because we already have these standards that we just have to follow. And then the last step, before you go to accreditation of a learning program, we register the learning outcome, which we've not gone over that hurdle, right? So we are in the process of developing, then we'll go and register the qualification. They will validate, bring people that are qualified to validate the registration of the qualification because you can come up, before you can actually come up with the curricula itself. So we are still at this stage here where we are developing the qualification, and hopefully by February we should be submitting for registering and validation and accreditation of that qualification. The next thing, obviously, if we do get that, is to do curriculum, to develop curricula. When developing a curricula, it becomes much easier because when you look at the requirements of developing a qualification, it actually makes it much easier for you to then come and fill in the curricula. What is it, the content and all that. So when you've developed a qualification and it's in the framework, institutions, for them, it's much easier to develop a curriculum. And even for us, and I want to believe for all institutions, you have a curriculum development policy that guides in terms of how you develop a curriculum. You have your needs assessment, which you would have already done in the justification of registering that qualification. And then you have to show that you have resource, infrastructure, human resources, and all those things And then it has to go from approval to approval depending on your institution. At our institution, it comes from the department, faculty, senate, council, and then it goes to BQA. Points to consider, hopefully I have about 2 minutes. One of the things that we needed to consider in terms of thinking about developing this program is the qualification of the staff members that are already in existence in the college. Because one, if you're going to develop a program and you don't have anybody who's qualified, obviously you have to train, that's money, right? You have to recruit other people, but fortunately we do have people that have been trained in UTC who already have a master's in psychology or a master's in clinical psychology. The one thing that I did not highlight is that, and I want to believe it applies to all institutions, you cannot teach a postgraduate diploma when you have a degree. So you have to have your qualification, your highest qualification has to be higher than what you're teaching. So, or one level higher. So now, unfortunately, we don't have a lot of people with PhD in our school. And therefore, it made more sense to actually say, okay, postgraduate diploma, because we already have people with masters and they have the UTC ICAP from Colombo Plan. The other issue that we also are battling with is availability of practicum sites that will be specifically for addiction. Like in terms of general mental disorders, we do have, but specifically for addiction, we only have one outpatient rehab in Botswana. It's something that we have to think about before we start the program, so that we know that our students are going to be attached. And then, not to make matters worse, but to make us think we have less qualified people out in the field to actually supervise these people, because they also need to have a qualification higher than the people that they're supervising. We actually thought, why not actually have our own private practices and we extend our services to actually include and have the students just come. So 5 hours of the week, we all rotate at my private clinic so that we can supervise the students, because it becomes much easier like that. And then infrastructure is not so much of an issue in the college, but in terms of service provision outside. Okay, the target audience I've already highlighted that it's one of the things that we've had many discussions with, but who are we looking for? It's people with relevant bachelor's or master's degree, because this is a postgraduate diploma. So with counseling background, I think I'm going to be stuck with a counseling background. Obviously, we also recognize learners with prior learning that do not necessarily have a bachelor's degree in terms of our admission criteria. With that, I want to leave my 5 minutes over, and thank you.
Maybe one question. Is there any, like one person? I'm sure there's more questions, but.
You're making me nervous, so I say more questions.
Good morning, all. My name is Dawah Sanisai from the University, Kano, Nigeria. My name is Epami. I must say that I thank you for the nice presentation, and you have nailed some of my concerns. And apart from the psychiatry and addiction, I also have a background in health economics. And one of the concerns I have is when you develop a program, it has to be market responsive. Because if you train a person and then nobody is demanding that, then the cost will die down in a short period of time to get graduates in the system. For my colleagues in Nigeria, I don't know for the countries, I know that if you're going to develop programs, especially like a graduate program, you have to look at the student size. Because if you have a graduate and then it's not, his qualification is it has no place in the scheme of service, then the employers will not know where to place it, what to do. So we have to consider that. Some of the courses we want to do, we have to really target probably people who are already employed, and then it's more like continual education level, so that we don't go into that kind of problem. Thank you very much.
We'll take maybe just a really short break, 10 minutes.
You have a question?
You can ask her personally. We got way behind, and so I want to try to get that. But we'll take maybe 10 minutes and the next panel will come up with everyone. Okay. 10 minutes, and then we'll go to the next panel. So ask your questions individually. Take this time to connect with people.
I have a very simple question.
Yes, I will try.
Nicely done exercise, by the way. Tell me, you mentioned that you do or plan to do some evaluation and research on this project. You plan to publish it. Really nice case study, and I think that it can be very simply publishable.
Okay. And the mic?
Yes, the mic is here. Give me the mic.
Okay, we're gonna get started.
Here or here?
Stand. Right.
I stand. I stand and I see my pictures. Okay, thank you. Good afternoon. Good afternoon, morning. Good morning. Good morning. Good morning. Sorry, I have done so much this morning. I feel like it's up in the day. So good morning, ladies and gentlemen. It's nice to see you once again. I told you my spirit has always been here from the first day. And today I'm happy that I will spend the rest of my day here and get to see the end of this beautiful forum. For those who were not here the first day, my name is Beatrice Kadongo from Kenyatta University. And this is a session which is actually a panel more than a presentation. And the reason we thought this panel was important is because if you remember in the presentation we had the first day, we emphasized that when we train professionals to treat SUD, it is important that they are not just theoretical graduates and trainees, but that they are able to do something. And therefore, one of the spirit of the UTC curriculum is that it is a how to do, because you can have lots of theory, and eventually when someone places a client in front of you, you have no idea what to do with the client. I had someone say that I hold a PhD in this field, but if you put a client in front of me, I have no idea what to do with the client. So this discussion and this session is geared towards articulating the value of connecting our training in drug demand reduction to the experience of actually practicing something. And so the question we ask ourselves is, when we offer a curriculum in treatment of SUD, what should the graduates of that curriculum be able to do? So we're going to be sharing our own experience as Kenya of how we did it and what we have been doing to try and connect theory with practice, so that when our graduates leave and go into the market, and I was happy someone presented, I think it was the Nigerian team that was talking about the importance of ensuring that your trainees find a place in the job market. So one of the challenges we learned over the years is that unless you connect your trainees to the job market, you are never going to get them placed for employment. And that then means they will not invest in your education. So you will have a wonderful program, but nobody is signing up for that program. And so we realized that over time, practicum was such an essential component of any training in DDR, particularly if your program is treatment oriented. And therefore, what I have with me today is a panel of members who do different things. Some work in Kenyatta University and some do not, but they've been brought on board because they are partners. I also shared in the presentation I made the first day that if we want to be successful in rolling out DDR programs, education programs, we must connect and collaborate with the market, with the placement sites. I had Botswana here share their concern about where do you place the students. So part of what we're going to be addressing in this panel is basically those issues. And so allow me to introduce the panel, beginning with the chair of the panel, who is Dr. Mushiri Karega. He's the head of Department of Psychology of Kenyatta University, with experience in many areas, including family therapy and counseling. Next to Dr. Moshiri is Dr. David Kokonya. Dr. David Kokonya works for a university in Kenya called Masinde Muliro University. But before then, he worked as a psychiatrist in one of the government hospitals in Kenya. And we had the privilege of placing our trainees in his hospital for practicum. So he was a site supervisor. And that's why we thought he was very appropriate to be in this panel and share with you his experience of what it is to be a supervisor on the ground, receiving your trainees that you're training in drug demand reduction education, coming for attachment site. Next to him, I want to skip him for a while. And I want to move to the gentleman at the far end, Mr. Joseph Mwangi. Joseph Mwangi runs a treatment center in Kenya, private treatment center for drug demand reduction. Actually, it's a drug treatment center. It is called Blessed Talbot Recovery Center. It's one of the most established treatment centers, which is actually following evidence-based practice, accredited by the national authority, that is ICUDDR, and we're very proud of his treatment center. And what he does is that he's one of the practicum sites where the students we train are placed. And so he also will share with us the experience of receiving trainees in the field and what strengths they have and what gaps they have, and give us feedback on what he thinks we should do if we want to make our programs better. Next to him is Madam Mary Kamina. Dr. Mary Kamina works in Kenyatta University in the Department of Psychology. She's actually the coordinator of the practicum activities of the Department of Psychology. So she comes here to share with you some of the experiences, administrative, logistical, that are required when you want to think about making your program practical. And finally, last but not least, the young gentleman there is called Stephen Moshiri. Stephen Moshiri is actually our student, first of bachelor's in psychology and currently master's in psychology, who is on practicum attachment and was attached in Blessed Talbot Treatment Center. And so he completed his practicum attachment and he did, I believe, a nice job. And so the director of the treatment center chose to keep him as an intern, a paid intern. So he will be sharing his experience of being a student on practicum attachment, what he discovered, what the challenges were, what the opportunities were, and what advice he would offer as a student, so that we also hear the student perspective. And of course, the chair of the panel, Dr. Moshiri, will be giving you the administrative perspective, because being the chair of the psychology department, there's a lot of logistic things involving, including connecting institutions. Because when you talk about practicum, you're talking about connecting now your institution in another institution. Sometimes they are administrative logistics. So that is the panel you have in front of you. And so I want to welcome the chair and just say something. I am informed by Kim that because we are zooming this live, for you to be heard everywhere else, you must come and stand here. So there's a rule. So when Dr. Moshiri asks you a question, you stand here and you answer. And he too must stand here to talk. So that is the basic rule. So ladies and gentlemen, let us welcome the panel. Thank you.
So good morning, ladies and gentlemen. So you don't just stand here, you make sure that you upper body fits into this little box for purposes of recording. So like was mentioned, Moshiri Karaga is my name. I head the Department of Psychology at Kenyatta University. My specialization is in marital and family therapy. And I want to start off with just outlining the agenda for this discussion in point form. I know Beatrice has done that. So I don't know which button it is we are pressing. Okay. So, all right. So I'll just outline the objectives of this discussion as was mentioned, and then we will go into the specifics. So it's not a long presentation. We're essentially going to share experiences, challenges faced in the conduct of practicum from the perspective of educators or trainers, and then, of course, service providers, both those that run sites, supervisors in the sites, and now we have the perspective of somebody that has been a student in the site. We will then share positive experiences and strengths in the conduct of practicum, discuss expected outcomes of practicum. What is it that as institutions, as departments, as programs, what are the outcomes we're seeking when we engage in practicum? We will have our students go for practicum, and then identify best practices, and hopefully from the discussions we will engage in, that will come up. And it will be nice as we open up to hear what people are doing in different countries and jurisdictions with regard to practicum. So perhaps the first question is how educational institutions select sites for practicum, and what criteria do we use in site selection? Which is a good question for those of us that already engage in practicum and for those that are yet to develop programs. I will just remind you all that as we speak right now, we do not yet have a program running that's specific to addiction. The Kenyatta University experience is that of counseling psychology. However, we do place students, we do have students going into treatment facilities like Blessed Town. In fact, I do not know the exact percentage, but a critical mass of our students end up working in facilities that do treatment for drug addiction. So I will begin by asking Mary Abina to come here and just brief us on what it is that we do in Kenyatta University in site selection, and I'll just fill in to the spaces where we need some more clarification. Very good.
Thank you, Dr. Mushiri. I'll first of all start by saying that we have a structure that is put in place for the requirements of the students, trainee. First of all, they must have covered all the core units that are in theory. And during theory, they are also interacting with modeling and doing skills application among themselves during the unit in theories. But however, during practicum, we prepare students to have their own self-awareness and to have mental wellness through attending to personal therapy. And the minimum requirement is 10 hours for each student to have covered, so that they go through their own self issues that they may need to process before they see the clients. Before now we select sites, we know that is the first experience that our student learners are engaging to interact with the physical clients. Previously having done a lot of theory work, actually, like Dr. Beatrice said on Monday, we do 14 units before we go into the field. So how we select the practicum sites, we select from a variety of hospitals, drug rehabilitation centers, and among other psychosocial settings like prisons. But what is very clear and important to us is what those sites offer. So in our department, we have a database of previous experiences with our collaborators that give us opportunities to train for us, our students. So over and above the database that we have gathered over the years, we ask our students to give us their experiences, and we continue building on that database by recruiting or adding into the number of those practicum sites, as we call them. The sites that are preferred to us are sites that are offering a structured format of attending to the clients, so that they are not only seeing the clients, but they are also recording or doing what we call the recording and doing what it takes for them to have the records of their training, the assessments, the treatment plans, and engaging into final referral for the clients. So those preferred sites also have structures of the personnel that offer the services to the student learners, because we expect them to be taking through the supervisory and advisory services to our students, learners. So above all, we have the registered or the qualified, the sites with qualified personnel are among the ones that are accredited. In Kenya, we have quite a number, very many rehabilitation centers, but NACADA has the record of how many are registered. So they could be between 20 and 30. Then we have our national hospital, which has all areas of expertise. We have all the wards and medical facilities that they offer, also rehabilitation for drugs, among other services. So we include our services also for choices that are offering not only the practice, but those that can follow up and take up to answer the questions and for which the university expects, the feedback that the university expects from them. Thank you.
All right, thank you. I'll just add one or two things. We do have students in our programs from all over Kenya who learn in different modes, so in the full-time mode, in the part-time mode. We have what is known as a continuing education mode. So there are times that there are instances where students come to Kenyatta University to study our different counseling programs, but are based in different counties, some which are far away, and can only access centers in those areas. So while we would like to, for example, only have them work in accredited facilities, that is not usually the case all the time. Because in some counties you will have rehabilitation centers that are not accredited. I believe right now, obviously we can clarify with NACADA, there are probably over 200 rehabilitation centers in Kenya, but not all of them are accredited. Just another thing to understand, and I know we'll come back to this when we talk about supervision, is that psychological practice in Kenya is not regulated by the state. Right, and I will touch on that when we have our questions on supervision and see how that influences our student experiences, as well as just those of us that are psychologists and how it is that we engage with our students both in school and outside. So the second question would be, and I know we'll come back, and a number of you have questions about queries about question one. What structures do academic programs and post sites have for monitoring and evaluation of practicum? At this point, I will ask Mwangi, Joseph, and then Dr. Kokone to come and give their experiences. Karibu.
Thank you. Thank you. Okay. So, thank you, Dr. Muchiri. How is everyone? My name is Joseph Mwangi. I'm the director of the Blessed Albert Recovery Center. It's a drug abuse treatment center, residential. Most of our outpatient is only a kind of an aftercare for those who have already been there. Our staff include 5 psychologists. We have 2 visiting psychiatrists. We have a 24-hour clinical officer, psychiatric nurse. Then we have the other support staff. Initially, when we started offering placement for practicums, we didn't have structures. But I think the moment a treatment center starts operating, some interested people express their interest, and because of that, the treatment center may now be forced to come up with the structures. Some of the people who have done practicums at our place include psychiatry students, counseling psychology students, both bachelors and even masters. We've also had a few PhDs in the counseling psychology. So what we do when such students come, we have a policy about internships and practicums. We attach them to a member of staff, and then if it's a real practicum, I have found universities where it's not really a practicum, it was more of a community experience. I think later I got to know there is a difference between a practicum and an internship. But usually they shadow someone, and then we try to involve them in all the activities that we do. We have a protocol of treatment that begins with client entry, then screening, clinical assessment, treatment planning, then the delivery of the actual treatment, in their family therapies, spousal therapies, client education, all that. So what we do with our interns, everything is documented and systematized. And we try to involve them as much as possible. I think I would say those are the structures. Then also, before we admit someone to take part in the practicum, the university must have written to us and we document that. Usually the university, especially Kenyatta University, we have been collaborating very closely, and they have a structured program of following up on students. I think that is one dimension I'm also seeing some universities lacking. So they have a tracking device of what is expected of the student by the time the practicum is wound up. And then internally, we have our own documentation processes where the student on the practicum is expected to participate under the guidance of a member of staff. I don't know whether I have answered that.
And we'll come back.
Okay, thank you.
From yourself. Okay.
Morning, colleagues. Yeah, I worked in a center which provided mental health services, and I designed the place as an academic center. We had over 7 universities, including Johns Hopkins. We sent us to students at one stage. But I had quite a bit of experience with the Kenyatta University. The experience probably I would like to share with you is what exactly a site supervisor should do. And one thing that is critical is to send students to a site supervisor who has an academic interest. I had been with the University of Nairobi as a researcher, then I quit, I went back to government. So when I came there, I was already with a scholarly attitude. And I was quite happy to work with these universities, and they never paid me money. But Beatrice later employed me to teach her students. It was out of excitement. So the students come with guidelines, the students come with logs, the students come with the expectation that there will be a report from the field. And when the students come, the way we run the program is a minute-to-minute accountability of the student's time. And the students document from this time to this time, she or he is doing 1, 2, 3. as a center, my role as a team leader was to bring every staff around the student to ensure comfort and for the student meet the expectations. So it was a bit successful, but we also realized that being a mental health center, the students had never interacted with the judiciary, with the prisons, and with the police. And we got this from the feedback. We used to get feedback from the students, particularly me, in confidence, so that the student feels protected. Now, the students had to work and fulfill the hours they want to achieve on the ground. And they did that. They produced reports, which we signed, submitted to the university. But there was a problem, and that is disengagement from their class. One student from another university became too attached to a child, so had to come in to disengage her. But there is also another problem. When a patient gets attached to the practitioner, and the time to go back to the university comes, what's the rule of disengagement? Probably Beatrice and the chairman will answer this. However, in summary, it has to be an obligation, and every center must have recognition that the university must be supported, have the commitment, embrace the students, but above everything else, make students very comfortable. They had breakfast in mountains at my cost. They had lunch at my cost. Yeah. So we had. And by the way, I came with samples of some of the posts the students who have produced for those who might want to see. Thank you.
All right, so allow me to just give in some of what we do as a program to ensure quality. So how do we monitor and evaluate what's happening with our students in practice? So the students will apply to different things. I remember they will choose areas of their interest. There's some that want to go into hospitals. There's some that want to go into rehab centers and things. And they do source for the sites. We do not source the sites ourselves for our students. And then when they secure a site, they are required to submit a letter of consent for the facility. So that is submitted to the directorate in Kenyatta University that manages all attachment and practical for all students. So we will get a copy of that letter, and then the directorate in Kenyatta University will also get a copy of that letter. And of course, that happened because in the past people will claim that they were at sites and were actually not in those sites. And then our practical in Kenyatta University is supervised practical. So anyone taking practical will come in for a weekly supervision session. We usually have that on Friday. It does not matter the mode of learning. So interestingly, even the students that take the continuous education program and are living in different parts of Kenya are required to come to the campus that they're registered in and have their weekly supervision class. Okay, and Beatrice will speak to some of what we have done with regard to assessing competency. Because the time we did do this, and we developed a tool in certain ways in which we measure that. We also have site supervision. So every student of practicum will have a member of staff visit the site. And this is facilitated by Kenyatta University. So we will organize, make our requests for payment, and have members of staff leave. Sometimes that will mean travel, members of staff are staying overnight and the likes, taking trains and flights and the likes. And that site supervision is also structured. We engage the clinical supervisor or the manager of the student, the person supervising them. There are certain questions and areas in which we are seeking information concerning our students. We then engage the students on site And part of what we are doing is actually getting into activities that engage with the clients. So those will be client progress notes and events, and we are going through them and having an engagement with the students. Of course, that also has raised its own challenges with administration, which I might talk about this time. And then we also have different ratings and assessments. So when practicum is coming to an end, there is a report that the site supervisor will do for Kenyatta University. We send them an assessment to it. We also have the student rate the facility. And then when the students complete their practicum, they must submit a report of their experience in the practicum. So that's a combination of skills, techniques, treatment planning, all the treatment that we engaged in. We have also built in reflection papers, because one of the areas in which we really pay attention to is growth. Are they growing emotionally, psychologically, in awareness of themselves and their lives? So we do have a comprehensive report. And recently we actually came up with a new rule that the students must complete and pick their graded reports prior to us entering their grades into the system, just because we didn't have to read about reports. I did mention that we also have specified hours for every level of practical. We have a BA in counseling, we have a master's in education. So they all have a minimum number of hours. And in that minimum number of hours, we have a minimum number of client contact hours. So there are certain requirements, and I know Beatrice will be speaking to that also. And we also do have a requirement for personal development. So those are some of the ways in which we do our monitoring and evaluation. And the third question at this point, and that is, does practicum seek to develop specific competencies among students? What are these competencies and how are these measured? So I'll begin by asking Beatrice to come speak to that, and then I'll ask Moshe to come and give his experience.
So just as we try to connect this, we try to connect the machine, I would just like to share a few reflections and say this. This is a journey we have walked and made lots of mistakes along the way. Our practicum, our counseling program began in 2004. That is 14 years ago. And up to about 2008, the market was saying they were not interested in our graduates, because they would say, your graduates are very good in theory, but they have no practice. And they would actually prefer to employ students from tertiary colleges in their institutions. And so sometimes our students would graduate from our program and go to the tertiary college to do a diploma or a certificate to get the job. And I said that was degrading of a university. So we looked at ourselves and asked, what is it that we are not doing right? And one of the things we did, we sent out a tool to our practicum sites. And we said, we would like the site to tell us about our students. So what are the strengths you have observed in them? That includes Dr. Kokonya. What are the weaknesses? What do you think of our program? What are the strengths? What are the weaknesses? I tell you, the feedback was enormous. And I'll tell you some of the weakest areas our students had. Assessment, treatment planning, documentation. So we analyzed that feedback repeatedly, a semester after a semester, and we took it and we said, it is time to relook our curriculum. And we realized our students were always going for practicum. But you see, when they come to your site, you could give them 101 jobs to do. Some of them would make them do clerical work for the 3 months. Others would make them go to buy tea and lunch. 3 months, that's what they're doing. Others will be arranging the offices, but they are on practicum. So they'll bring back and tell you, I have been 3 hours on practicum. So we sat and we realized, you know what, we have to ask ourselves, what is it that we want the student to achieve when we send them out? Because the practicum site isn't going to determine that for you. My dear university colleagues, the practicum site, unless you have a wonderful site supervisor like Dr. Kokonya, who had come from the university, that's why he had an academic interest, a lot of other sites would care. So you will send your students to them and they will make them do everything except what you want them to do. And so we had to define what is it that we would like our students to achieve from practicum. And so now every time we send out students, at the end of the semester, as we are evaluating the students, we are also, and the site is evaluating the student, we're also asking the site to evaluate us as an institution. And I tell you, the feedback has changed. From not wanting our graduates to looking out for our graduates. What Mr. Mwangi should tell you is every semester when we send our students for practicum at his site, and we go around to see them for practicum supervision, the site have retained them. I told you that Blessed Talbot has retained Moshiri. He's still a student of master's. He completed practicum and the site decided to retain him as a paid intern. And every other place, they are looking out for our graduates. And it's all about what is this practicum about. And that's why I want to spend a little time talking about how we did it. So we sat, and with all that feedback we were getting, we developed competencies. And so I have a document here with 14 different competencies that we identified that our students must have. And I do know this is going to be very similar to the DDR program. So the first competency is just ability to be self-aware. You heard the doctor say how students get connected to their patients and clients, and when it's time to leave, they cannot disengage. Part of it is because they are enmeshed in their relationships. So one of our key competencies is just to help the student trainee become aware of themselves. And so you can see competency number one is increased self-awareness, and it describes what it is that we look for. And it also says what are the sources of evaluation that we are going to use to determine that competence. So for example, for increased self-awareness, one of the things they are going to be doing all the time, you have been told that they have every week a class of 3 hours. During that class, they present their cases. Why do we want to have that? Because we realized some of the sites we send the students to will not have a competent site supervisor, clinical supervisor. They'll have an excellent administrative supervisor. And I did hear Botswana saying about their concern. And I want to encourage you and say this. Your students need not only go to rehabilitation centers. They can go to a government hospital that has a psychiatric ward. They will meet clients with substance use disorders. But they may not meet someone who has the competencies to supervise them for clinical work for this area. So that means that sending students for practicum is not the typical easy way of saying we can rest this semester. Not at all. In fact, you're going to have to do much more than you are doing when you had them on campus, because you have to keep checking what are they doing with clients out there. Because this is also about ethics. Because if you send your clients to work with patients and clients, and they are causing psychological damage to them, who is answerable? You are as an institution. So this is actually a very daring decision you make when you decide to offer this course. So you must be ready to also take up more responsibility. So we look for the ongoing casework presentation that they do in class. We see the level to which they are self-aware, the level to which they're able to see that here I'm getting enmeshed with my client. We ask them to do reflection papers. I think the chair talked about that. They're very powerful. And we also look at their case notes, which they document for every client session. And you can see the range. We grade them between high, moderate, and low, depending on, and this is continuous. The second competency is the ability to apply relevant theory. I mean, we do know that we must practice with a theoretical foundation. So we want to see that our clients are appropriately applying the relevant theory, the relevant skills, and the relevant skills that we have taught them in the coursework units that we have been doing. And again, where do we look for that? We look at their ongoing case presentation. So as they present the cases of what they are doing with the clients in the field, we're able to see, are they integrating theory? Are they using evidence-based theories? And how are they doing it? The second source of information, there is something, a report we want them to give at the end of recording one client's audio recording with permission and consent, and they transcribe it. And when they transcribe, They also have a column where they put in the skills and theories they were using. So we look at that also to see whether they have an understanding of what it is exactly they were doing with the client. And the third one is the site visit, when we visit them and we ask them to actually make a presentation of their best case. And sometimes we also ask them to make a presentation of their worst case, and that helps us to pick. The third area of competency is the ability to conduct assessment and formulate diagnosis. We want clients, we want our trainees to be able to say, I sat with this client. I didn't just sit. Someone once said that you counselors, what is it that you do with clients when you sit in there? Psychiatrists in my country like to fight counselors sometimes. A lot of respect for them. So sometimes they will say, you counselors, you walk in there with clients. When they come out, they have nothing in their hand. We doctors, they walk in, they come out with a prescription. So we have had to take time to say, what really is it that we do with clients when we sit there? And so formulating formal and informal, and I'm going to be talking about formal and informal diagnosis. So we assess, we want them to be able to use the DSM, and you know that substance use disorder is also classified. And I should have told you that this gentleman was actually a contributor to the DSM-5 through the UNODC. So we are very privileged to have him support us. So we want clients, as they present their cases, even if they're not working in a clinical setting, they must at least produce or spend some of their time doing formal assessment and diagnosis, being able to do a mental status examination. Sometimes we realize, and this is important for SUD training because of co-occurring disorders. Sometimes you're there treating a client for see they are psychotic. So we want them to be able to demonstrate ability to do that assessment, use the DSM, formulate diagnosis, work alongside psychiatrists and say, from my assessment and formulation, I think this client could have depression. I want to refer them to you. And the client, the psychiatrist takes it over. And again, we have the various levels. The fourth competency is the ability to conduct informal assessment. Now, those of you who may be working from a purely counseling model may know that in some places, there is no provision for formal assessment. For example, if you work in a prison setting as an attachment site, they do not allow you to even have any paperwork as you work with the client. The interaction is nothing, you're there and you're sitting. So you must also be able to make a sort of an informal clinical judgment that gives you an idea of what it is you're working with. So we also insist on that. We want them to see how logical you are in your thinking, what critical intake information you pick, how systematic are you in the way you link up the specific subsections. And then competency number 5 is the ability to formulate a treatment plan. I think all of us who are doing SUD training know how important it is to formulate a treatment plan that you can use and that you can evaluate and you can also implement. So that is competency number 5. And 6 is about implementing it. And we look at their presentations and see what they are doing. They must do case notes throughout, and we ask them to put together the case notes of every client that you've seen over the period, and we evaluate how well you're flowing in implementing the treatment plan. And we even have a template for the treatment planning so that they're able to see what to put in that treatment plan and how well they are adhering to it. And then number 7 is ability to evaluate that plan. Again, we look at it very critically, looking at all the issues you pick with your client. So if you pick your client as an SUD problem, your client has a family relational problem, your client has HIV, how have you addressed all those issues in your treatment planning and implementation and achievement? Then number 8, we look at the ability to conduct case management. I think we know that our clients who come with SUD have all types of issues. Some of them it's employment, others it is medical, others have legal. So how well is the student being able to pick those issues of the client and link them up to the various service providers that they require? Then we have got number 9, which is very critical for us, the ability of our students to be able to do follow-up and ongoing care. A lot of our students previously would see a client, finish with them, and that's the end. And they would say the client left after that. And the question is, are you connecting that client to an ongoing care, even beyond your contact with them? Are you able to help them beyond the counseling session you have, continue having recovery? So that is very important for us. And number 10 is the ability, very critical for us. I told you our weakest point was every service provider, every center said our students could not document. So we take this seriously, ability to document and keep relevant records. They must have case notes, and you know how tedious it is. After every client session, they make case notes. We have client logs. They must log in, for example, undergraduates log in 300 hours, masters log in 500 hours, PhDs log in 1,000 hours. They must log the client contact hours, they must log the practicum hours, and we distinguish between practicum hours, I was supposed to be here, and client contact hours. And I'll explain to you why. I'll explain, I don't know where I am now, I forgot, just realized. So I don't know where I'm being recorded from at all, if at all. So now we realize that we must distinguish between client contact hours and practicum hours. Because a practicum hour can have several things. It can have a client contact, it can have a research on the client issue, it can have a case conferencing about the client, it can have supervision. So we realize we want clients, we want our students to learn to engage with the client. Because we realize many of them would go to sites, do all those wonderful things, do presentations, do conferences, do research, but then you put a client in front of them, you don't know what to do. So that's why we distinguish between client contact and practicum hours. So we have got login sheets for the client contact hours, we've got login sheets for the practicum hours, research hours, supervision hours, and all that. So that's how rich our documentation has become. The number 11 is a competency that's extremely important. The ability to work with multiculturally diverse clients. We all know that across the settings our students will go to, they will find diverse clients. We want them to be able to work with all those clients. If you're male, work with females. If you're coming and you know our country, like you may just know, we have a lot of challenges of diversity, particularly ethnic diversity. When we have a political year though, when we have no political year, we don't remember that we are diverse, like we're very diverse here. But we are okay now. But the day the politics come, we forget. Forget that he was my brother, start thinking of politics. So really, for us, our clients' ability to engage with clients in a professional way across multiple cultural settings. And we love the model of Hay because Hay says that diversity is not just about ethnicity, it's about age, it's about disability, it's about developmental stages, it's about religion, it is about ethnicity, it is about socioeconomic, it's about sexual orientation, it is about immigration status, etc. It's about nationality. So we really want to embrace that and ensure that our students are able to work with that. The number 12 and very important is the whole idea of professionalism and ethical business and law. Professionalism, ethical, and legality. Well, we did say that right now we're not regulated actually, and that's the problem in our country because we had to make decisions about this as a university. I'll tell you, it's not happening in every university because there is no law that is telling us you must do. But we realized if we wanted to remain committed to our program and to our clients, then we had to do these things ourselves. So the issue we seek for is that our students are working within ethics of whichever profession, actually not necessarily Kenyan, but even global. We want to make sure that they are working within the law. And that way, then we know that we will not have problems. Then number 13 is very important to us. Sometimes our students will go to practical sites and they will not find the ideal setting that they were trained to find. So they were told that you work with a client in a private, wonderful room. Then you go to a mental health institution, which is public, it has a lot of patients, and there are no counseling rooms. And you ask the nurses and the doctors, where do I hold this session? They tell you under that tree. And many students get frustrated and say, I need to find another site. Then you go to the other one, and you go to the criminal justice system, you're told you can come to the prison. And then you go there and say, okay, I want to see the counseling room. And you know the counseling room is bad, but you have to cancel with the door open, and the soldier has a gun and moving around you. All right? Just to make, and you ask them why, and they tell you to make sure you're safe. Because this client is so we have had to teach our students the ability to navigate the diverse situations they come across. And that's why for us, this competency of ability to be creative and innovative and work in diverse settings is a critical competency for us. And finally, number 14, which is very important, again, we've learned along the way, sometimes clients will come and you will only get to see them once and you will not see them again. And you have this lovely treatment program that tells you I will see clients for this number of sessions. So when a client sees you once, you're so frustrated wondering, did I really do anything? So we have had to add this competency to help our students be able to work with clients that are short-term, clients that are in crisis, because sometimes A student will come and tell you, so I met this student, this client, they were like this, like this. The next time you hear the client died, because the student did not recognize the red flags, all right? The crisis the client was in. So this is a competency we've added after again realizing how critical it is for our students to be able to know when you have a client in crisis and how do you address it. So really, in a nutshell, that is part of the competencies that we look for when we send the students for practicum. And when we get the feedback from their reports and their scores, then we now ask ourselves, has our curriculum delivered? Many times we have had to get the feedback and go back to the courses we were teaching and start strengthening them. And one of the areas we've had to strengthen is to say that in our coursework units, we keep doing little micro counseling so that we don't wait for practicum for the student to meet the actual client. So if I'm teaching group counseling, actually the two ladies you see manning the desk of ISSUP Kenya are my students that I taught group counseling last semester. And so when I told them I'm looking for volunteers to come and support this, they volunteer. Now, during their class, that one semester course, part of the class task project is to run a group. So that as they are learning the theory of group, they're also practicing. But that means I have to do extra supervision because I have to monitor what they're doing. I have to ensure the clients are safe. But the advantage is that when they are through with that course, then by the time they go for the practicum and they are told to run that group, it's on the first time. We do that for our different courses. If it's family, if it is assessment, so we have simulations of cases, we have them do micro counseling and recording so that we strengthen them before they go to the actual field to meet now the two people here who are running treatment centers. Thank you very much.
So thank you, Beatrice. Before I ask Shuri to step out, I just want to emphasize the importance of getting feedback from the stakeholders. And she mentioned it before she got into the competence document, that the documentation begins from the site. All the paperwork we require students to engage in, and the rating from the facilities at the end of every semester, and then after the site supervision. In fact, as I speak, a number of staff are out in the field doing site supervision. We then collect all that information and then use it to make decisions regarding our program. So Moshiri, welcome. You can just talk to us about your experience and also competencies. Did you get any mentorship during practical? You know, what has the journey been like?
Okay, thank you very much, Dr. Moshiri. So my name is Stephen Moshiri. I'm a master's student in Psychology Department, Kenyatta University. So I want to share briefly my experience in working at a treatment center, drug rehabilitation center. So first and foremost, I would like to say that for a student who is in school, a practical experience is a very important experience for him, because sometimes we have our own expectations of the way maybe our clients are supposed to be or what to expect. But when we get on site, we find very different things. So that's why it's very, very important before one begins to practice, they are able to have a practical experience. So just to share a few of my experiences. First of all, I've been able to learn that in dealing with the drug rehabilitation and treatment, it's more of a multidisciplinary approach. I came in as a counseling psychologist, but then I was able to learn that I cannot be able to work alone with a client. I need other practitioners in the area. Because sometimes you may find that a client is admitted into the center, maybe because of their intake or their drug use, they may present with psychosis. So as a counseling psychologist, I cannot begin counseling that individual, even if I'm the one on site or I'm the one on duty and such a client presents. So I have to have that awareness to know that this client, I cannot start dealing with this client. So I need the help of a psychiatrist. I need the help of a psychiatric nurse or a clinical officer first to be able to stabilize this client so that I can be able to journey with the client. So I've been able to really learn that treatment and rehabilitation is multidisciplinary. And then the other important thing that I've learned while on practicum is that addiction is a family disease. So a client may be very much willing to undergo the treatment. The client may have the necessary insights required to go through the program, but you realize that if the client doesn't have enough family support, if the client doesn't have enough community support, it becomes a really big challenge to journey with the client. And that's why also family therapy has been a very important factor and a very important part of the program that we've been running at Blessed Albert. So in terms of assessment has been one of the most important skill and area of competence that I've had to learn and I've had to exercise from time to time. From mental assessment to all areas of clinical assessment, and I've had to familiarize myself with the use of the DSM-5. I have had to attend numerous sessions and to sit during the psychiatric review, because we usually have a psychiatric review every week. So I've had to sit in those sessions so that I can observe how the psychiatrist is doing the review so that I can learn from him. Because remember, Dr. Beatrice has talked about the formal and the informal assessment. Because sometimes a client may be brought to the center, but the psychiatrist is not on site, the psychiatric nurse is not in, the doctor is not in. So as a psychologist, I need that extra knowledge to be able to identify that this client is presenting with these symptoms. So I need to contact the psychiatrist. I give this feedback, and then the psychiatrist can know what to recommend. So assessment has been a very, very important part of my learning journey. And then also, speaking of mentorship, there's something that we've been doing at the center, and that is when you are attached there as an intern, you are given a practicing counselor who has been there for some time so that they can be able to journey with you. Because it's not just about doing the counseling itself, but there's a lot of documentation. And we usually have the practicum logbook that we are given from the university. And then also I was privileged to work at a center where they have a very systematic and rigorous documentation system. So the documentation itself can be very rigorous, and you may find yourself even having some burnout. So it requires that you have somebody to journey with, somebody who has been working there for some time, somebody who can guide you through the documentation, because the documentation begins from when the client is admitted, when you are trying to do the background information, the family history, to when the client will be discharged, and when you are trying to do the follow-up. So I've really gained a lot in terms of mentorship and working with the other colleagues that have been working there for some time. And then something else that has really helped me in my practicum is the case conferences that we usually do. At our center, we have the case conferences every Wednesday. So we take hours and we sit down and we discuss the progress of our individual clients. And at that point, you are able to receive feedback from your fellow client, from your fellow counselors. You're able to receive feedback from the doctor. You're able to receive feedback from the psychiatrist. And this really helps you when you are journeying. So the case conferences have been really, really important. And also during the case conferences, we are able to do peer debriefing, and also we are able to receive peer feedback from each other, which also helps us in terms of reducing burnout. The other important thing that I benefited with during the practicum is the clinical supervision, both on site and during the weekly classes. So you realize the time when I would go sit down with my supervisor, Mr. Mwangi was my clinical supervisor, and I was privileged because he had been practicing and also he had been lecturing at the university. So I really gained a lot from him. Even today, I really enjoy when I get to sit down in sessions that he's taking through, whether family therapy or a group session, and I really benefit a lot from him. So the whole concept of clinical supervision and mentorship has been very, very important in my journey. And then also something important that I've learned from the practicum is being able to work with culturally diverse clients. So you realize that sometimes my idea before was that addiction is the same for everyone, but you realize that sometimes, depending also on the demographic characteristic of your clients, they may present differently. For example, an adolescent who comes to the center with a drug addiction may not be necessarily the same as a young adult who comes to the center. Maybe the adolescent is using the drugs because of the identity crisis. The young adult is dealing with the relationship issues. So being able to differentiate between those demographic characteristics has also helped me a lot. And also being able to understand the cultural background that the individual is coming from. Because also sometimes, even in our country, the drug itself can be culturalized. I remember a time I had a client, and the client was an addict of Mira. So he was telling me, now, how am I going to go after treatment? And in our culture, when we have a certain celebration, I must eat Mira and I cannot skip that. So you see, I had to understand the cultural background that the client is coming from to be able to assist him through the process. So knowing how to work with multi-diverse clients has also been very, very important to me. And yes, and then lastly, the issue of case management, being able to take the client through the whole process from intake to discharge and follow-up. And we have follow-up sessions, and also depending with the client to client, we also have an halfway house at our center where when we realize that a client requires more help beyond their program, we provide for them halfway house where they have different activities to engage in. So I can say that my experience has been very helpful, and now I'm more competent and I'm able to journey through with clients of different diversities and different backgrounds. Thank you.
Thank you, Moshiri. Just for clarity, there's no relation. And I know he has a strong interest in technology, so you will look for the gentleman see if you can end up in Czech Republic and do your PhD. So I don't know if we have time. Okay, so before we open up for questions, I just want, for those of you that don't know, you mentioned a drug called Mira. That's cut from twig that is chewed a lot in Kenya and Ethiopia, parts of the Middle East. Yes, so any questions, perhaps?
So I'll leave this here for. No, you'll need to answer. So let me do it. Oh.
Thank you. It is you are able staff. My deepest respect for this really perfect, just because it's wonderful exercise, wonderful example, published book, well structured, perfectly prepared, technology. Comment is also very simple. I see that they have a few universities. I don't know, 5, maybe 7, maybe 10 universities, perfect practical, and including documentation, including assessment systems. I see the perfect opportunity for comparative. Describe these models, compare these models, and at the same time provide to other universities these documents. You will be willing to do it also. And I think that it will be a really perfect exercise that can help them to be a really help to other universities and other colleagues where it's possible to do soon. Absolutely brilliant.
Thank you.
Hi, everyone.
Thank you. It's really a comment, I think, because in South Africa we do all that you were saying, that you were presenting, and even everybody on the panel, what they were saying. But I think the one difference is that in South Africa we've got a regulatory body through the Health Professors Council of South Africa and then the Psychology Board that actually look at scope of practice for within psychology. And I think it helps to have, and I've listened to the 2 days of engagement, and I think that in Africa, we really, every country have to make sure that we get regulatory bodies for psychology, because I think in some countries, people are registered under health and allied professions, and that becomes a problem. Because what we have is every 5 years, the Health Professors Council come to each university to monitor, to evaluate the program. Then they interview students, staff, ex-students, interns, and sites, and if you don't stick to the competence or the scope of practice in terms of the training, you can lose your accreditation. But what that allows is for all universities in South Africa to have the same criteria in terms of training. It also regulates the internship sites where students are placed to do their internships. And I think because what you've worked out in terms of the competencies and things, because that's actually what's regulated by the Professional Board of Psychology. And it makes it much easier because then you have a unified way within the country of doing that. So, because, for example, if we had this conference in South Africa, you would have more psychologists here than psychiatrists, and I think it's the other way around. Thank you.
But thank you very much for your presentation. I've really learned a lot of it. Getting us notes to take back to my own place. Yes, I'm speaking on behalf of our NGO that we run. I'm a university staff, but as part of the community service at university, we try to support academic staff. We have an NGO which is strictly for additional services. And it's one of the more legitimate of the university, the only NGO. We have similar things, we do similar things with you, because I have about 8 tertiary institutions that come for practical in my sector, but the students are vast. I have clinical psychology interns, social work, education science. I will have those are due to theology and biblical counseling, and medical students and residents in psychiatry, they all come. But as for that, for you, for the clinical psychology, I think you do far better than my own place, because in terms of the supervision, and the supervision of the children practical, because most times they send the students to us, and because we try to maintain UNC standard, they have supervised us, and we are scared because we are a private sector, and we know that certification anytime, so we have to measure up to their standard, and then we have a national minimum standard we have to maintain. And if we don't do that, we're threatening to withdraw our license. So we have to keep it. So because of that, the universities and high schools just relax. They don't do much observation. They just come once, maybe in a while, to supervise and see what is happening. But they leave it to my clinical psychology. We have criteria and everything, to actually for supervision and weekly reports and so on and so forth. So they find out that we do most of the things that is expected. So they don't come from their own end to supervise their students. But we on our end, because we are to meet a standard, we have to do that, and it's been very tasking for us. But since we have diverse of our students going for our practical, when they come, before we start orientation, we have to keep the orientation for the minimum standard, clinical standard, and the ethical standards, and we ensure that they don't have any contrary information to what the team is giving the time. And so that helps us a lot of problems, because most of them are not able to speak about it, and when they come, it's something that I don't used to. So we have to do orientation, take them down all the departments, introduce them, and then tell them all the minimum standards of what is expected of them, how they cannot get the interaction with the clients, confidentiality, privacy, so on and so forth. not giving money to class, not giving them so many totally errors for class, so on and so forth. So we do that before we take the various development admin who will now continue with the explanation. Sincerely, I've learned a lot from you. I'm taking so many things to go and challenge them, say, wake up and to catch up with okay. Thank you.
So, Bill, quick, okay, or a question.
Okay, just a very quick observation. Very glad I came with my co-teacher. So that if you can, it's very good to hear what's going on. So that, so we have an MOU with them. We have 3 treatment centers with 2,500 clients. So it's very good to see the expectations. So I say to the South African gentleman and the Nigerian, I hope when we get the Google Doc up, you can load all. Why are we, let's load up all these documents from the templating so that we can, we can take things that are already working and, then launch in our own country.
Yes, so I think that there's a general feeling that that's something that we need to do right away, not in the distant future. And so I do have this document that will be the first thing I propose. Let's thank our panel. I think this was a great. Is it too short?
Yeah, I was off. Yeah, I just want to thank you also. Without a few comments on it, I want to know whether there is any form of rotation of students. From our experience, if students go to, say, a psychiatric facility, they meet different situations. If they go to, say, an old people's home, they meet a different situation. If they go to the primary school or primary school, they meet a different situation. So in my university, we do rotational engagement. So that students get exposed to different things. And we have, for master's students, we have full 1 year after coursework for these rotated postings. So I think that if probably you rotate the students, also the benefits will be better.
Okay. So here's what we're going to do. I hope you're okay with this because this is policy. What I thought we would do, we were going to have 2 separate discussions, one that talked about problems and the other one that talked about solutions. And I think we'll just combine those and talk about needs and how to accomplish those needs all in one conversation. I'm going to speak for a minute. So I'm going to have INL come up and speak for just a moment, and then we're going to take our lunch break. And maybe we can try to get back here a few minutes early, not take a whole hour and a half, maybe take an hour, and then we can get started. Please do come back because the discussion, all of this is supposed to lead to the discussion, and if you don't come back to the discussion, then I'll be broken-hearted.
We could not break Dr. Johnson's heart. That would be a crime. I'm going to be very brief, but I'm mainly here to just express how amazed I am personally. And some of you may not know me. I'm sorry. My name is Bill McGlynn. Oh, that's right. Thank you. Usually the video of me is not particularly helpful for an audience, if you know what I mean. Anyway, my name is Bill McGlynn. I am a senior advisor with the Bureau of Narcotics and Law Enforcement. And that's the Department of State's, the Foreign Ministry for the United States. And we are the prevention and treatment part of it and international cooperation. And you've already heard from actually someone who's much more of a colleague than certainly I am of you, Dr. Thompson, and Alan Paracha, who's done an amazing amount of work on this conference overall, is also here. But just to say, we are just amazed at how much you all have done in the ICUDDR and the kind of talent and capacity that you, as the top level universities and educators, bring to this whole issue. And we're just delighted to be a partner in whatever way is most effective. A lot of that, I think, means not getting in your way and stopping you from doing great things, which we will not do, I can assure you. But at least some of our efforts are focused a little differently, maybe some populations or some practitioners that we want to reach out to, and are, you know, that's definitely a top priority for us. But the partnership we have that has developed and is going much further with you is just, I think, making it to a level that really will have a systemic change. And all that you bring to your universities and changing your own countries, I think, is just so impressive. And we look forward to seeing how this develops in the future and continuing to be a partner in any way that you guys think is appropriate. Thank you.